Hello and welcome to the Canadian Cancer Society's Expert Angle webinar series. This webinar is titled Prostate Cancer and the Color of Your Skin. Today's guest speaker is Dr. Danny Vesprini, a radiation oncologist who treats prostate and breast cancer at the Sunnybrook Odette Cancer Centre in Toronto. He is an affiliate scientist in the biological sciences at the Sunnybrook Research Institute and an assistant professor in the Department of Radiation Oncology at the University of Toronto. Thank you all for joining us today. If you have any questions for our speaker today, please click the speech bubble button on the top left of your screen to submit your questions. Our speaker or an information specialist will get back to you as soon as possible. Dr. Vesprini, I will now turn this webinar over to you.
Great, thanks very much. It's a great opportunity to talk about a very important topic, so I'm very grateful for the Canadian Cancer Society for providing this platform. Because as you'll see, what we talk about today is there's lots of stuff going on. There's a high-tech research, so many advancements. You hear about the news all the time, but in fact, in a lot of cancers, and particularly prostate cancer in this population, so those with dark skin, awareness probably is the #1 thing that would help how people do in the future. So I just have a couple disclosures first. I do research in this, not particularly a lot of the stuff we're going to talk about, but a little bit of the stuff we're going to talk about in regards to genetics, the inherited predisposition for prostate cancer, and that's funded by Canadian Cancer Society, which used to be part of the Prostate Cancer Canada, as well as funding from the Ride for Dad, which is supported by TELUS. A lot of that funding goes into a program that I am the principal investigator at called the Male Oncology Research and Education Program, or MORE program, which we have at the Sunnybrook Odette Cancer Centre. And that's following men at higher risk of developing prostate cancer, such as those that have known genetic predispositions, such as the BRCA1 or BRCA2 gene. Those have a very strong family history of prostate cancer, so multiple people in their family that have it, or those that have very early onset prostate cancer where we think there might be a genetic component. And what we're going to talk about today is those of Western African or Caribbean ancestry. So there's a lot of work going on. This is just a small snapshot of what kind of I've seen and what I think drives certain points home. But first, I'd like to discuss a little bit about the basics of cancer. I'm an oncologist, I'm a clinician, so we see people all the time. And I think dispelling some of the myths and making sure people understand a bit about the disease is important. And I like to take an anthropomorphic view, so giving the cancer as if it thinks and as if it has human qualities. So cancer is a disease where normal cells divide without control. They just keep growing and growing, and eventually gain the ability to invade other tissues and organs. So the way I like to describe it to my patients is, if you took a gash out of the skin of your hand, that tissue's gone. And then the skin cells will grow back until they touch each other, and then they stop growing. That's called contact inhibition. Cells know that when they have to touch each other, that's it, you don't need to grow anymore. Cancer cells lose that ability to stop growing. They will keep growing and growing and growing on top of each other, creating tumors. Eventually, they develop some advantageous to them change that allows them then to grow somewhere else. So in general, most cancers will only grow in the tissue that they come from. So for example, for prostate cancer, the prostate cancer cells are growing. People always say, oh, you can drag it out when you biopsy or you move things around. That's not true. Almost all cancers have access to the blood. In fact, most people have cancer. If you take out some of their blood, you will find something called circulating tumor cells, or CTCs. The cancer has access to the blood. The cancer doesn't know how to grow in other places. But eventually, most cancers will develop that ability to grow in your lymph nodes or in your bones. And that's when they start to metastasize or push outside the organ and cause pressure onto other organs. So that's kind of the way cancer works. In most cases, it is a stepwise development into something that becomes more serious. So finding it earlier is probably the most important thing for most cancers. And the other thing that's, I think, a myth that needs to be dispelled a bit is that prostate cancer cells are what they are. So prostate cancer is prostate cells. It doesn't know that they're cancer. It just continues to grow as a prostate cell would. So for example, for prostate cancer, it continues to make, in most cases, PSA, the prostate-specific antigen. That's the blood test that we use to measure how much prostate people have. So when someone has prostate cancer that then spreads to their bone, that's not bone cancer, that's prostate cancer. And that's a common thing that we hear of in the clinic, where people say, well, my mom had breast cancer, but then she died of bone cancer. She probably died of her breast cancer that spread to her bones. And those are important things to clarify because it changes what we do from management, but also it will help in regards to what treatments to do, and it's just the understanding of the disease. And I guess the main question that a lot of us are trying to answer is what causes the cancer? And there's very few cancers where there's one answer to that. In general, it's what we call it's multifactorial. So there's multiple factors that are coming together that make this cell that was normally a prostate cell become what we consider cancer. In general, most of these cells have mistakes in them that then lead to something that causes them to become a cancer. Most of those mistakes happen in our genetic material, our DNA. And what they do is they, as stated earlier, they forget to stop growing, so they'll continue to grow forever, and they learn how to invade other tissues or spread to other parts of the body. So that's a very basic way of thinking how cancer becomes what it is, from a normal cell that is you to something that can become much more aggressive and dangerous. So how do we accumulate these excess mistakes in our bodies, and generally is in our DNA? Well, the majority are random, and I think that that's what people have a hard time wrapping their head around, is that the majority of cancers are not because you had stress, it's not because you did anything bad, it's because it just happens. Part of evolution for all species is developing mutations or changes in the genes that then develop some advantage to that animal, that person, into something that provides them the ability to live longer. So for example, changes in our skin, changes in how we metabolize certain foods that we may have access to. That's the thing, though, over hundreds of thousands of years, these little mutations, these little changes that happen in our cells, we develop into something that is more likely to survive. So survival of the fittest, as they say. Every single one of our cells, of which we have trillions in our body, makes over 1,000 mistakes in its DNA every single day. And we've developed very intricate mechanisms to repair that DNA because you can't have that much errors. But every once in a while, in your trillions of cells, having thousands of mistakes a day, one will happen in a gene that then provides some advantage to that cell that then may eventually become a cancer in the future. That's why if we all lived forever, we'd probably all develop cancer, because eventually it's going to happen. Some cell is going to make a mistake, have an advantage. 5 years later, another mistake, have an advantage, and we will develop cancers. Those cancers in men tend to be in the prostate. In women, it tend to be in the breast. So that's the randomness of cancer, which I think that some people have a hard time kind of accepting. But we do know that obviously mistakes can happen based on carcinogens in the environment. So the pollution we breathe in, there's chemicals we're exposed to at work, there's radiation we're exposed to. I'm a radiation oncologist, we do this every day, but we all are exposed to radiation. It's in our food, it's in our basements because there's rocks in the ground that give off something called radon. It's when we fly in a plane, we get exposed to radiation. So there are multiple things that kind of we get exposed to that are very hard to get rid of. Other than maybe smoking, which provides some radiation, these are very hard things to control. It's just part of being alive, and one of the reasons why probably over the years, the rates of cancer have slowly gone up if you compare to historical. There are some infections that can cause these mistakes. The most common one, the one that we should all know about, is the human papillomavirus, so that causes the common wart. There are a couple of strains of the human papillomavirus that cause cancers in the cervix as well as the anal area. They do lead to that cancer. One of the most common types of head and neck cancers that we see in the throat and then the back of the nasal patches is from this virus. It's not from smoking, it's not from drinking. So we see a lot of young people now getting, because human papillomavirus is very prevalent in the population. There is a vaccine to this, so vaccines save lives and people should consider having them, and parents should consider having their children vaccinated for this, because in the future they'll likely be exposed to this virus. But there's really nothing been shown definitively in regards to prostate cancer. There's a few studies recently that something called Epstein-Barr virus may or may not be related, but it's very hard to kind of associate these things. And lifestyle, smoking being the big one, of course, not exercising, eating poorly, these things all probably slowly increase the chance of having these mistakes, and therefore maybe leading to a higher rate of getting cancers. And these are the things that you can control, but you probably may not want to. Full disclosure, I don't jog. Probably it's good for you, but I mean, at the end of the day, I think that we all have to do things to try to minimize these excess mistakes. The problem is very hard to prove in a large population that one thing has a significant advantage, other than maybe not smoking and not having excess amounts of alcohol. But otherwise, it's hard to prove that jogging around the block decreases your chance of cancer, because it may, but that may be a lifetime change, decreasing your risk by 1% over your whole life. It's very hard to prove from a scientific point of view. Genetics. So that's part of the main research that I do, is looking at the genetics of prostate cancer. We're inherited with these things. We have 46 chromosomes, 23 come from our mom, 23 come from our dad. It's a mix of what they have. This is what you're going to get. There's nothing you can do about that, at least now. There may be technology in the future that can change that. But essentially, some people are just born with a mutation in the gene that predisposes them to getting cancer in the future. The most common one that we hear about is the BRCA1 or the BRCA2, or the BRCA genes. So the most famous example is Angelina Jolie. She has a mutation in one of these genes. Her has a very high risk of getting breast cancer because of that. So she had surgeries to decrease that risk. The reason why people with these mutations have increased risk of cancer is that BRCA1 and BRCA2 are genes that are involved in DNA repair. So they actually repair those mistakes that happen every day. So if you have only one copy of that gene, you're fine, because it still protects it. But eventually, because of living, if you lose that one the only functioning copy of that gene, you now lack that gene that makes the protein that repairs DNA, and you're going to make a lot of mistakes that other people won't make, so you are more likely to get cancers. We know that increases risk of breast ovarian cancer in women, and increases the risk of pancreatic cancer in both men and women. And for men, it really increases the risk of prostate cancer, which is very, very aggressive disease, and one of the main areas of research that we have at Sunnybrook in the MORE program. You can't control what you inherit. You can blame your parents, but you can't do anything about it. So these are something that you should be aware of, but you can't change yet. So a little bit of background on prostate cancer before we get into the specific part of this talk. So in general, prostate cancer is what we call a clinical presentation. It usually presents with localized disease. The vast majority of men diagnosed in the modern era are diagnosed because they have a PSA blood test, which is a simple blood test that we recommend doing once a year. We'll talk a bit about that later. And a digital rectal examination. So the prostate is very close to the area, the end, just at the tip of the finger. When you do a rectal examination, you can usually feel it. If there's something abnormal, then there's a higher likelihood that that person has a tumor in there. Locally advanced disease, so very aggressive prostate cancer that maybe is pushing on the bladder, so causing problems with urination, or that's already spread, thankfully is relatively rare in the modern era. It tends to be in men that aren't screened, so men that don't have PSA tests or don't have digital rectal examinations. We're seeing a little bit more of it, a bit of it now, because PSA testing kind of fell out of fashion in the last 5 or 7 years. But it's still something that is relatively rare, thankfully, because that's a very aggressive disease that sometimes is hard to deal with. So if we think someone has prostate cancer, we take a full history. What's your family history? Did your father have it? Does your brother have it? Do that physical examination, including a digital rectal examination, and then blood work. So the simple PSA test, which is a blood test, gives us a sense of, if a PSA is high, because prostate cells make PSA, that's their job. If the PSA is high, it either means someone has a very big prostate, so they have lots of prostate cells, or they have prostate cancer. So more cells than they should have because the cancer continued to grow. Then we do what's called a biopsy. So that is a sampling of the prostate to get a determination whether or not there are cancerous cells in there. Again, this is a relatively simple procedure. An ultrasound goes into the rectum. Needles are put into the prostate either through that area right between the rectum and the prostate, or what we call transperineal, in that area of skin between the scrotum and the anus. We usually do 10 to 12 needles, sample it to see whether there's cancer there. Increasingly, we're using MRIs first to get a good sense of the prostate, and then if we see a tumor, which my hand is this ring, is we can make sure needles get into that area so we adequately sample it. There's a bit of an access issue to MRIs in Canada, but it's something that is slowly increasing, because a lot of men may not need the biopsy if the MRI shows there's nothing there. And then those men that have prostate cancer, particularly those with higher grade, will do what we call staging, a CT scan, make sure there's no cancer in the lymph nodes or the bones with a bone scan. We will usually do an MRI of the prostate to fully get a sense of what's going on in the gland so we can help with treatment decisions. And there's increasing use of something called a PSMA scan. And that's a special type of CAT scan that uses a special dye that really specifically binds to prostate cancer. It's not widely available in Canada. You will certainly hear about it in the rest of the world. Whether it helps in the beginning, we don't know, but it's something that can be helpful, particularly in men with very aggressive disease, to make sure their cancer hasn't spread. Once someone has cancer, we then have staging. So prostate cancer doesn't use stage 1, 2, 3 like you normally talk about. We use risk categories. These involve what's called the T stage or the tumor stage, and that is essentially what we feel with our finger when we examine, or what we see on an MRI. So this is an MRI. That's a cross-section of someone's body looking from the bed upwards towards their head. The prostate is right in the middle of the body, the rectum's behind. And we can use that to determine, is the cancer outside of the gland? Is it pushing into other organs? And that's how we stage people. Most men have what's called T1, which is a tumor that is within the gland itself. It can't be felt, and it was picked up usually because the PSA test was abnormal, the PSA blood test. T2 is when you start to feel it, but it doesn't feel like it's outside the gland. It feels like it's within the gland. You can feel a bump. T3 is when it's getting more aggressive. It feels like it's pushing outside the prostate itself or up into the seminal vesicle, which is a gland like a rabbit ear that sits above the prostate. Those are signs of aggressive disease. And T4, very aggressive cancer that starts to invade other organs like the bladder, which sits up above the prostate, or the rectum, which sits below. This is pretty uncommon for someone to be diagnosed with this in the modern era, but we see it from time to time, of course, unfortunately, because not everyone has PSA testing. Once someone has a tumor and we do a biopsy, they get a grade. So what we used to call Gleason score, but we're moving away from that into something called a grade group. So the most common thing people will be aware of is Gleason score. So Gleason is a famous pathologist, and he made this. What it is a score of how aggressive the prostate cancer looks out of 5. And you take the two most common patterns. The most common pattern is stated first. And essentially what it is looking at how the tumor looks. The more unorganized it gets, the more, so this is normal prostate, nice round, what we call glands. And as it gets more erratic, it starts to look less and less like prostate. And then the pathologist will grade this based on what they see. So if there still looks like there's some glands, but it's looking a little funky, that's called a Gleason 3. And then if it becomes very erratic, big sheets of cells all clumped together, that's called a pattern 5. And you put these two together. So for example, when a man has Gleason 7, he could have mostly pattern 3 and some 4. So we used to call that Gleason 7, 3 plus 4. If someone has just low-grade cancer, that's Gleason 6. That's the lowest Gleason score you can have. There's no such thing as a Gleason 5 because Gleason pattern 2 is not cancer. So we have what we call intermediate risk. Those are men that have Gleason 7 cancers, and that's either 7s that have a lot of 3 and a little bit of 4, that's called favorable, or a lot of 4 and a little bit of 3, and that's called unfavorable. And high risk are those men that have Gleason score 8 to 10. If there's any of this high-grade cancer pattern 4, it needs to be identified, even if there's just a little scrap of it, because this is the stuff that actually has a huge risk in regards to how people do in the future. And we're seeing more and more clarification in regards to the different types of pathological variants. Something called cribiform is just a pattern what it looks like, or intraductal, the cancer is going into these little ducts. Those tend to be poor prognostic factors, and when we see those, even if someone has a lower grade disease, we start to take it a bit more seriously. We're going away from Gleason score. We're going towards something called grade group. This is a little table that kind of explains it, and that's because Gleason 7, for example, is a huge range of guys. But we know that the guy that has just a little bit of pattern 4 cancer is going to do a lot better than the guy that has 95% of this cancer pattern 4, and we should change our treatments based on that. So grade group 1 is just kind of redifferentiating these groups to kind of put them in smaller bins, so it helps us make decisions, and that's correlated to how people do in regards to treatment. So we use risk categories, not stages. Low risk are men that have very small tumors, so maybe you can feel it, but it's not very big. You have to have Gleason 6, so low-grade cancer, and a PSA of less than 10. These men we put on surveillance. We don't treat these guys. Intermediate prostate cancer, maybe the tumor's a bit bigger, can have Gleason 7 disease, and usually have a PSA between 10 and 20. So if you have any one of these, you are now called intermediate risk disease. High risk disease are men that have either very big tumors, high grade, or a PSA greater than 20. You have any one of these factors, you're automatically considered high risk. You're treated as such. And then very high risk are guys that maybe have it locally advanced, it's into the rectum, or those guys. Some men unfortunately come to us with metastatic disease in their lymph nodes or their bones already, and we treat those men very differently compared to the earlier stages. But getting to what the talk's actually about, the issue is that Black men have a higher risk of developing and dying from prostate cancer. That's been recognized for some time. Some of the research we're doing is looking at inherited reasons for that. And this is just data from the SEER database, a big US database looking at across the country in regards to those men that access care through their system. And as we see, so this is the rate of cancers per 100,000 people. Non-Hispanic Black men have a very high risk of developing prostate cancer as compared to, for example, non-Hispanic white men, as well as the other ethnicities that they've captured here. And this correlates, unfortunately, to death. So if you look at the death rate per 100,000 people for Black men compared to non-Black men, it's more than double. So a Black man in the United States that develops prostate cancer is 2 times more likely to die of their disease, looking at these types of statistics. This is better represented, I think, in a worldwide thing, because that's US. There's lots of complicating factors in regards to the way US people access care. If you look at, this is called a heat map. So a heat map is looking at a pattern or a map such as this, and what happens is based on how many people have what you're looking at, the darker the color goes. So this is the incidence of prostate cancer if you look around the world where we have data. Not surprisingly, those countries that are industrialized, that have healthcare systems that do PSA screening, have a higher rate of prostate cancer. So Canada, United States, Australia, Eastern or Western Europe, these have higher rates of prostate cancer. And that's not genetic, that's because they're testing. Certainly, if you test for prostate cancer with PSA, you're going to find more cancers than in a country that doesn't test. It says nothing about why, other than the testing. But if you look at mortality, so dying of prostate cancer, you'll see that these maps seem to change. So the industrialized nations tend to have less mortality, even though they have higher risk of getting prostate cancer, whereas nations that have maybe a lower risk of getting the cancer seem to have a higher mortality risk. And if we hone in on the kind of the area that we're interested in today, again, this is the incidence of getting prostate cancer, very high rate compared to the other places in Canada, United States, and in the Caribbean, it's kind of mixed. But if you look at mortality, it's these colors go very dark in the Caribbean, and that's because men from the Caribbean that get prostate cancer are more likely to die of their disease than men that get it in Canada or United States, and that's for a multitude of factors which we'll review now. So why does that matter? So as everything else, it's complicated. It's the answer you give your kids for everything that they ask if you don't know the answer. And we don't really know the answer, but we know that there's multiple things that can influence it. So social disparities. A lot of the data that we're looking at is in the United States, which I think accentuates some of these, but there's certainly a lot of difference in regards to access of care, economic disparities. Those of lower socioeconomic status are less likely to access care or be provided care. Environmental risks, we're all exposed to different environmental risks based on our diets, what we have access to. There's cultural behaviors that probably influence this in regards to how people perceive their disease, how they perceive different treatments, and of course, genetics. So we'll go over the non-genetic factors because in fact, those are the most important and the ones that we can actually access and probably the most relevant. So for example, Black men present with more advanced disease compared to non-Black men. This is probably because of many reasons, one being cost. Medical care is expensive, particularly in the United States. And we know that Black men are less likely to have financial advantage compared to others, and therefore they don't access the care. You can't afford to have the PSA test. There's education, awareness of what's the advantage of doing it? What's the advantage of spending the money to determine whether or not you have disease? And we can never ignore systemic racism. That's a huge problem in the United States in regards to accessing medical care. Black men are less likely to be treated aggressively compared to non-Black men. So for example, Black men that have aggressive prostate cancer are less likely to receive hormonal therapy, which is the injection we use to help with our treatment, even if they have very high risk prostate cancer. Part of this is cost. Hormone therapy is very expensive. Even in Canada, it's expensive. If you're not covered in Canada for hormone therapy, it can be between $1,200 and $1,600 every 3 months. It's a big ticket item if you are on a limited budget to start off with, as well as cultural. There's fear of side effects, which is accentuated in the Black community. in particular based on the fact that hormonal therapy has a huge impact in regards to sexual quality of life. Black men view their disease less aggressively and perceive aggressiveness is itself associated with outcome. It doesn't matter who you are, black, white, purple. If you perceive your bad prostate cancer as less aggressive, you're less likely to pursue aggressive treatment. That makes sense. It just seems there's evidence that black men view their disease less aggressive as compared to non-black men if you give them the exact same scenario. So that's a part of education, cultural, how people deal with their disease, how they approach diseases, what they believe about them, what they believe about what they should do. So certain cultures will believe of alternative medicines, using the bark of a tree instead of having traditional treatments. And that's something that's passed on generation to generation. Black men are more likely to consider cost, treatment time, and recovery time as important decisions. This is almost all economic disparity. So the cost is obvious, but treatment time is as well. Sometimes you have to be off work. They can't afford to be off work. Recovery time is important. How long am I going to be off work afterwards? Is it going to be a week? Is it going to be 2 months? Is it going to be 3 months? These will shape decisions based purely on economics. And black men are more likely to consider side effects to therapy. If you look at a panel of men of all different ethnicities or backgrounds, black men are more likely to look at the side effects of therapy compared to the effectiveness of treatment. And that's probably a cultural thing more than anything else. So we'll go into a little bit of the details in the next couple of slides. Well, that slide's a little messed up. So disparity in access. So this is cherry picking. There are lots of studies out there that you could go through, and these are just examples of why we think there's such an issue in regards to black men accessing care and doing well long term. So this is a study done several years ago that looked at, again, the SEER database, so this large medical database, and what they showed is that black men with advanced prostate cancer, so this is not subtle, these are guys with aggressive disease, were less likely to pursue aggressive treatment options. They're less likely to go for aggressive surgery or radiation, or the addition of hormone therapy with radiation. Again, this is multiple reasons why. The cultural aspect of, for example, hormone therapy, the cost of all the treatments, it's not cheap to get treated. Even if you're in the public system, there are ancillary costs that need to be considered, and there's a lot of lack of trust in this community in regards to both just the medical system in general, but as well as the individual providers. This is unfortunately going to be accentuated as we see less and less PSA screening based on the older recommendations to not do PSA testing or screening, and leading to prostate cancer being caught at a more advanced stage. So if you have a group that's already less likely to take aggressive treatment with an advanced stage, you're going to accentuate and make it worse in regards to long-term outcomes in the future. Perception. So if you look at African-American men in this study, they were more likely to consider the cancers not aggressive. So if you had the same cancer, which was thought to be significant, 54% of the African-American men was considered to be not aggressive, whereas only 24% of the white men would. And this kind of really, if you don't think your cancer is aggressive, you're not going to accept a therapy that has significant side effects. Both groups thought cure was important. So that's universal, and that makes sense. Like, everyone wants to be cured, and you think it's very important. But if you look at the black men in particular, they were more likely to think about cost, treatment time, and recovery time. So if you said that, yes, the non-black men, is it important to be cured? Yes. At what cost? Doesn't matter. I need to be cured. If in the African men, they would look at the treatment time, the cost, and all these economic factors before deciding whether or not it was important in regards to making their decision. Now, in this study, they tried to take what we call controlling confounding factors, things that are influencing decisions that you don't really have control of in the actual study. So, for example, the example I typically use for what's a confounder is women that have university educations have a higher risk of breast cancer than women that don't have it. It's clearly not because they went to university. It's because the confounding factors are that women that go to university have less children in life in general compared to women that don't go to university, are more likely to take the birth control pill, have usually children later in life because they're delaying their family planning, and all those things increase exposure of the breast to estrogen. So the confounding factor is these other things that are not in what you're looking at. And in this study, they tried to do that. And what they showed is that the perception of cancer aggressiveness itself, and of course wanting to be cured, were associated with receiving aggressive therapy, independent of whether you were black or white. So men that don't perceive their disease aggressive are less likely to have aggressive treatment and won't do well. And Black men are less likely to believe their disease is aggressive. So race itself in this context is not associated with treatment. It is education, disparity in economics, costs, and that which influence and why, at least in this study, Black men don't do as well as white men. This is probably the best study to date that I can think of that has tried to look at all the different factors in comparing how different ethnic backgrounds or in particular in this case, obviously men of Black race do compared to others. They had 300,000 patients in the analysis, 52,000 or so identified themselves as Black race. What they showed is that Black race was associated with increased risk of prostate cancer death. So men that are Black are 30% more likely to die of prostate cancer than non-Black men. They tried to adjust for all these confounders, which is a very complicated thing to do because for one thing, some of the confounders aren't even in the database, but they did the best that they could. And they said that there was still an increased risk of dying of prostate cancer, less than 1%, but not 0 at 10 years, which is a short time frame because a lot of men die of prostate cancer at 15 or 20 years after diagnosis, taking up very high risk prostate cancer. So there's still something about Black race, independent of all the confounders they can control for, that increases the risk of dying. There are also several studies, which we don't go into today, that show that men that have low risk prostate cancer, right, the stuff that we don't treat, the stuff we just watch, they are more likely to die of their disease than non-Black men, even though this is a disease that men shouldn't die of as long as you watch. That's probably a consequence of not trusting the system, not being watched as consistently as those that are non-Black. But certainly there's evidence that Black men don't do as well trying to control for all of these non-genetic or non-biological factors. There's controversy though. Another big study came out a few years before this one that said that they didn't seem to be different. Black men, just if you control for all those other things, seem to do just as well as non-Black men. So it may be access to healthcare that is the main determinant. But again, the data is very hard to sieve through because of all these things that we can't control for. Interestingly, I think not surprisingly, unfortunately, is that in this study, Black men were just more likely to die of anything. So if you look at all causes of death, Black men were 30% more likely to die than non-Black men based on their age, which is, I think we're certainly seeing a lot of that now these days, and hopefully that's something that the awareness in that part of things will improve things, because that's quite frankly a travesty. Genetics. So I think there still is a genetic part here. We all have to do research in different things to try to put these pieces of this huge picture together. And again, I'm cherry picking a few studies that I think that are interesting in regards to this. This is a study several years ago. They took a 5-gene panel. So these are 5 genes that we know are differently regulated or differently having mutations or changes in Black men compared to non-Black men. And they're what we call overexpressed. So they have different changes in them, and perhaps the genes that these genes are used more, or the protein that comes out of these genes is overly expressed, produced more than in non-Black men. And what they showed is that if you had a low gene score, so if these genes weren't altered in you, you did better. So this is a curve. Going down is bad, so this is those men that get treated and aren't cured. So if you had a low score, so these genes weren't really messed up, you did better. If you had multiple problems in these genes where they're overexpressed and these proteins are being made too much, those men didn't do as well. But interestingly, if you did that same panel in European men, it didn't make a difference. So there's something specific about these genes in Black men that when they are altered, they influence how people respond to treatment or the aggressiveness of the disease up front. But in the white men, it made no difference at all. How about just in general mutations? So something called genetic instability. So this is a concept where some people just have more mutations scattered throughout their genome, so all their genetic material compared to others. And what this study did was they took a group of European men, so predominantly Caucasian, and a group of African American men, and they looked at the entire genome based on all these different genetic changes, which we call mutations or polymorphisms, so they're just genetic changes. And they didn't look specifically at genes, they looked at all the genes that they had access to. And what they showed is that there are more mutations in DNA in general in tumors from Black men, so they took the tumors out, looked at it, compared to European men. So there's just something going on in the Black men that are producing more and more mutations. which suggests that Black men have more DNA instability or genetic instability than men in European, at least in this study. And this more mutations that we see in the tumors may contribute to more aggressive prostate cancer, and why Black men don't do as well as non-Black men when we diagnose them and after we treat them. And one of the reasons could be DNA. So as we talked about, BRCA1, BRCA2, they're genes that are involved in making a protein that repairs DNA. If you can't repair DNA, you make more mutations, and therefore you're just odds-wise more likely to make cancers. This is a study that looked at a panel of genes that we know are involved in repairing DNA. And they compared mutations in the genes that make the genes not work between African American and European men, and whether it impacted prostate cancer survival. And what they showed is if you look at the African American men, if they had no mutations in these genes, that's the red arm, they did well. You know, some men still don't get cured, but mostly do relatively well. But if men had even one mutation in one of these genes, they didn't do as well. So they are more likely to have other problems that then lead to aggressive disease or not respond to the normal therapies. If you looked at the European men, made no difference. So again, specifically in Black men, African American men, as they've termed in this study, having mutations in these genes impacts how well men do in regards to survival. So they were less likely to survive if they had a mutation in one of these genes, where that wasn't the case in European men. And this is important because it may help identify targets for treatment. If we can determine why mutations in these genes lead to poor survival, we can target that pathway, that process that led to that, to maybe stop it or find a way to reverse it. And that's what we call personalized care. Identify things within the individual person or individual tumor that'll then allow us to make decisions, whereas treatment A may work for African American men because of this, whereas it's of no value in European because they don't have that problem. And although I do think still the majority of the issue is not genetic, we clearly have families in our MORE program that you look at it and you're like, there's something inherited here. So this is a pedigree, which is a family tree. Squares are men, circles are women. When people are connected like this, they're married, they have children. So this couple had multiple boys, a girl. Black means the person is affected with whatever you're looking at. In this case, it's cancer. And this is a family that I follow, a couple of guys in this family, where all 6 of the brothers got a cancer, either prostate or pancreatic, in their early 50s. That is not random. That is not dietary. This is genetic. There's something in the father, and their father died. This crossover means they have died of prostate cancer. Another family, a very complicated family with multiple people. This is of Jamaican ancestry. So this man and this woman had children. He died of a stroke, but he did have prostate cancer. So they had 3 of their sons had prostate cancer in their 50s. So again, this is something that these men have had genetic testing. So they've been in our program, we do genetic testing. The problem with genetic testing, or the issue with genetic testing, is that you can only test for the genes you know. And our thought is that there's something in the African American, Caribbean, Western African ancestry line that we don't know that causes cancers. And in part it's because there's less access to them. These men are less likely to engage in programs, so we just don't have the databases. As you know, in the previous study we talked about were those certain genes that are influence the cancer risk in Black men, but not in European men. One of the problems is that a lot of the studies we have are based on big European databases. So we're looking at the genes that influence cancer in Caucasians. We're not looking at men of African ancestry. Tends to be of Western African, and that's because the slave trade, right, populated the Caribbean and North America, and it seems that risk goes wherever men from the Western Africa live long term. So these are reasons why, you know, although I do think the awareness is the #1 issue, we still have to do work on the genetics. It's the tip of the iceberg. We don't really know what's going on. So we need more and more research like we do in the MORE program and other places around the world to try to elucidate why this is the case. So, but that said, really the social cultural barriers are really ones that we need to overcome. There's a lack of awareness of risk, misunderstanding of screening and treatment. Education is important, engagement is important, lack of trust in the medical system. Black men are severely underrepresented in the medical and scientific world because of systemic racism and all the pressures that have been put on over the years. lack of trusting relationship with health professionals themselves. This is the case everywhere. I'm not trying to say that Canada is like this wonderful fantasy land, but certainly it's accentuated in the US, as we're seeing right now, unfortunately. And prostate cancer screening and treatment is seen as a threat to masculinity. This transcends color, but culturally there are different differences, and we all know you get prostate cancer, you might need treatment. That treatment may lead to loss of erections, and that is a fear that a lot of men have that we need to overcome. Like I tell my guys, you can't have sex when you're dead, so let's cure you. If unfortunately you develop a problem there, we'll deal with it. There's ways to try to remedy that. So the take-home messages are: you can't change your genes, not yet. There is new technology that allows us to change genes in cells, which is pretty cool, but that's not prime time. But you can find out if you're at risk. If you have a family history, discuss genetic testing with your family doctor. Maybe get referred to a genetic center for more in-depth assessment. Get tested. Have a digital rectal examination. Nobody likes it. We don't like doing it. It's the only reason you shouldn't do one is if you don't have a rectum. It's a simple test. It's not a big deal. And every once in a while you find something. So PSA testing. So the controversy does exist. PSA test in general is recommended by most of our expert groups for men that are greater than or equal to 50 years of age. You should discuss the pros and cons of testing with your family doctor. CCS starts to recommend discussing PSA testing at 45 and above, particularly those at high risk. There are some guidelines for men at very high risk. For example, those with a BRCA1 or a BRCA2 mutation, which we know can have very aggressive prostate cancers, maybe to discuss testing at age 40. We lump in other men with high risks of developing prostate cancer because of family history or those of African or Caribbean ancestry to start to consider PSA testing at 40, maybe as a baseline, but it's a reasonable thing to do. It helps awareness. It gets us into the mindset that's important. And then at the end of the day, it's not a big deal, particularly in Canada where these things are covered. So PSA testing is covered if the doctor thinks that you're at risk. So PSA testing is you have to pay for in Canada if you're just screening. So I don't have a family history of prostate cancer. If I start to do PSA testing, I'm gonna have to pay the $35. But if I had a family history, my family doctor would click off, I'm insured, and it would be paid for. So that's something that people should discuss with their GPs or their urologist or other people that they follow. And us researchers will continue to look for genetic risks. Those people are doing social economic. We'll look at that, and eventually, hopefully, we'll have more data to allow for personalized treatment. Identify what's the problem, what's going to work, do we need to treat, are we treating aggressively enough, do we need to have new agents developed? That's all the stuff that is going on. So just to acknowledge, our program here at Sunnybrook is big. It's one of the biggest in the world that follows men in this situation. Justin Lawrence is a genetic counselor that works with me. He's kind of the co-lead. He is the one that runs this program. I'm just the doctor that gives the royal wave in the back. A large multidisciplinary group across the world, including in the UK and the USA. So we have multiple studies ongoing looking at these things. And I just want to thank everyone for listening. I look forward to the questions. People that are interested in kind of being involved or even have questions, I'm very contactable by email. And I hope this was of some benefit. Thank you.
Thank you so much to Dr. Vesprini for sharing this information about the risk of prostate cancer in Black men and the need for getting tested. We appreciate your time and expertise. The Canadian Cancer Society is dedicated to supporting people affected by cancer in all stages of the cancer experience. To help us make sure we are providing the information you need most, please take a few minutes to fill in our short survey about this webinar and what topics you would like us to cover in the future. Finally, we would like to make you aware of the Canadian Cancer Society's free information and support services that you can access online or over the phone from the comfort of your home. These services are confidential and many are available in multiple languages. Our Cancer Information Helpline can answer your questions about diagnostic tests, treatments, side effects, clinical trials, coping with cancer, COVID-19 risk, resources, and many other related topics. Call 1-888-939-3333 or email info@cancer.ca. Our online community, cancerconnection.ca, helps people who have cancer, cancer survivors, and caregivers share their experiences and build supportive relationships. For any other cancer-related information, please visit our website, cancer.ca. You can also live chat with one of our information specialists who can answer your questions and connect you with additional resources. Thank you again to our speaker today for joining us and sharing their expertise. This now concludes today's presentation, and on behalf of the Canadian Cancer Society, we wish you well.